afternoon to everybody. I don't have any potential conflicts of interest, and the case I want to present to you is that a man of 62 years of age with all risk factors and previous ischemic stroke and a very long history of current right coronary artery instant occlusion thrombosis. He came in 2009 with unstable angina. We placed a stent in the proximal right coronary artery. He came back after 1 month or something like that because he stopped his Plavix with thrombosis of the right coronary artery STEMI. We placed other 3 stents. Then he came with, on 2011 with again STEMI and very late occlusion of the right coronary artery. Again, 2 other stents, changing of the double aggregation. On 2012, again in another hospital with an infarction, and the result was angiography, again occlusion of the same right coronary artery, again another death. And during all these years and coming into my hospital, he had this critical stenosis of the bifurcation LAD and the diagonal branch. We don't touch it because we have a problem with the right coronary artery, but we thought that we have to resolve the problem with his left coronary artery. Up until 2013, several days before the last year PCR, he came with signs of unstable angina and signs of ischemia in the anterior wall. So we performed to him the right coronary artery was perfect, FFR on the right coronary artery was perfect, IVUS was okay, so we went to the left coronary artery, and the stenosis was the same angiographically, and he had FFR. We performed FFR to be sure whether to treat or not, because the case was complicated as a clinical case. So LAD was 0.058 and the diagonal was 0.71 FFR. We performed also the IVUS, and I will demonstrate that both are the view from the diagonal and the view from the LAD, both side and main branch of disease. We proposed to the patient bypass, but he refused the bypass because he was sure that we thought with all these years that we resolved this problem, maybe we are able to resolve also this problem. He definitely refused bypass surgery. So we decided to treat this artery, and my strategy was to use an Axxess, which is a dedicated bifurcation, self-expandable stent for the LAD and the bifurcation, and 2 biovascular resorbable stents, scaffolds, BUS, for the main and side branch. So preparation of the lesion as it's normal, with a normal balloon and non-compliant balloon. And here we can see my Axxess, how enters inside of the LAD. Maybe just here, maybe here a little bit wrong, because the angle to the diagonal is a little bit more better for the flowering of the Axxess stent. But anyway, the stent I placed it in the LAD, and it was, at the end, it was correct, this decision. So while the stent was there, you know, the opening of the stent you need to do slowly, but the patient demonstrated ischemia, severe ischemia, and was symptomatic. So I was restricted to start opening of the stent a little bit quickly, and you see that from the beginning of the stent up to this point, which we call it point of no return. I did it just in one movement. So when I tried to pull back the stent to place it in the bifurcation. The stent was entrapped inside of the LAD, and you can see here the catheter was pulling back the catheter. I was not able to remove the stent from the LAD. So what to do? Well, you know, it's a new stent. What to do? Well, I left it there. I left it in the LAD. So this is the result of the stent in the LAD. So I decided to change the strategy to pass to a provisional stent. This stent, I mean, well, the stent is there. So I predilate again the LAD, placed my BUS on the LAD, passed across the strass of the stent. You can see here that the stent is in LAD, and I passed with the balloon, predilated the diagonal branch, and placed another BUS there, kissing balloon. And the final result of this case, this is not a complication like thrombosis of the left main, perforation. This is a little bit, you know, different complication. So this was the final result of this patient, and FFR demonstrates a good result on the diagonal and on the LAD, and also I will demonstrate that the axis is the proximal part. You see it's okay, and the carina is well, it's okay, and both vessels, main and side branch, were okay. So it was up to the, before, when I sent this presentation to the PCR, but the patient had to do his follow-up. So his follow-up left was asymptomatic. In 1 year was asymptomatic. Left ventricular function was perfect. Better was his scintigraphy, no ischemia, effort ischemia. This patient, no ischemia. His angiotago CT scan was okay. You can see all the stent, wide LED, the diagonal branch, and the, let's say, disappearing of the tube IVUS, at least in the CT scan. So whether the private was okay, this patient. So to do coronary angiography after 1 year or not, well, I decided to do coronary angiography because his problem was the acute occlusions instant of thrombosis. So I performed the right coronary, I decided to do coronary angiography with angiography, FFR, and IVUS on all vessels. So here, I don't know, okay. Here you can see the right coronary artery instant restenosis, were one of the his occlusions, previous occlusions, and FFR was also, you know, 0.79, 80, something like that. But I was demonstrating that in this place the vessel was really tight, and angiography was that. So what to do? I decided, well, the only thing to do is to do depth balloon, at least in my opinion. So I performed one predilatation, and after that depth. And this is the result with FFR 0.83 and the IVUS. So with another guiding catheter, left coronary angiography, and there you can see osteal stenosis of the diagonal branch, proper osteal stenosis, and the FFR of the LAD was 0.84, so it's okay. The diagonal, the same thing, 79, 80, something like that. So whether to treat or not to treat, well, I decided to treat this vessel. So this is also, I will demonstrate that. I see in the second place, second image is up the ostium of the diagonal, and well, the same strategy to treat it with depth balloon, and here is the depth balloon, 3 millimeters. The stent was 2.5 absorb, but I used a 3 millimeters balloon. This is the final result. FFR 0.87, so it was good to treat this artery with the balloon. And also the IVUS was okay with these patients. Conclusions, in fact, you know, it's a little bit difficult to personally to after the last exam to take some conclusions, but generally I have to say, in some cases, like this patient, which is complicated patients, to use a self-expandable bifurcation test. The bifurcation maybe is a good idea because you use less metal on the carina, and the risk of the thrombosis is less, especially in these my patients. And obviously the axis needs a very precise placement, and which you can achieve with several projections, slowly opening of the stent, many contrast, a lot of contrast. But the good thing is that if it's not in the correct position, because it's the first time for me happening something like that, it's a relatively new stent. If it's not in the correct position, if it's after the bifurcation, anyway, well, I consider it like any other stent, and after 1 year, the angiography demonstrates that it's continuing self-expansion doesn't damage the vessel, so there is a solution if it's not in the correct position. About the bivascular scaffolds, obviously, the same patient, so difficult patient, it's not bad to use in this type of patient, this type of stents, because you know you have the possibility that in the future, if you have some problems, to retreat him, or even to leave some space for the bypass. Maybe he will come later for bypass. And well, IVUS, obviously the bifurcation is very good, especially in my case, like when the stent is not in the correct position. And I have to thank you for your attention. I'm living here, that's why I'm a fan of the bifurcation. I complicate my life with these difficult stents. Thank you very much.
Very nice presentation. Just a small question. Do you have an idea how much it cost, this intervention?
I do prefer not to think about that. No, I mean
cost-benefit ratio of all this story.
well,
Actually for a simple lesion, bifurcation lesion.
no, first of all, for the previous access to the hospital, obviously it is okay because the patient was symptomatic with infarction. The bifurcation.
No question about the indication.
Yes.
But just classical two-stent PCI would do the same what you did. Actually, with the highly dedicated bifurcation stent, we use it as a normal stent because it was wrongly positioned
in my case, it's a complication. The decision was to use it in the correct position, but it went there. It was impossible to pull it back. Two-stent strategy, I will not agree with you because this patient has a lot of in-stent thrombosis. So to suffocaricate, to put a lot of metal on the carina with two-stent, I'm not sure whether it was the best situation. Like planning the procedure, I thought about the bifurcation.
Any questions or suggestions from the floor, please?
I would like to underline the problem of this stent. This is a dedicated stent that if it's implanted in the right position, you can spare. You don't spend more because you can avoid to implant other two stents. Obviously, in this case, there were maybe some. I don't know if you did a right lesion preparation because it's very important to make.
Yes, normal balloon and non-compliant balloon.
Maybe you open a little bit more than normal.
I arrived to the point of no return and the stent was almost opening the small LAD and it was not possible.
And you deliver the stent just in the main branch. But if you use this stent in Medina 111, you don't have any problem to implant the other stent because you can cover with one stent 3 lesions. Thus, I agree with you that it could be more expensive, but it could be less expensive.
Every complication
we are
is
starting
expensive.
this type of dedicated stent.
Yeah. I
Just to
felt
make-
theoretically I can agree, but this stent is nothing new. This is a mini-square technique for bifurcation for Medina 111. But usually you end up with two-stent technique in Medina 111.
No, you can use only this stent because you
it's
just
half
two small
millimeter.
arms.
No, it enters almost 2 millimeters inside of the carina, so if the lesion is short, you can cover one Medina 111 just with one stent. In
Yes,
this
but
patient,
it doesn't cover the flow divider. Carina is not even touched by
Exactly.
the stent. So carina stays, and if you have stenosis on the carina...
but I did IVUS and my IVUS demonstrated the carina was...
Yeah, IVUS is another 1,000 euros.
This is a special patient, it's not like any other patient.
I asked you a question. I was surprised by the use of scaffold in this particular setting. Why did you decide to use 2 scaffolds in such a complicated bifurcation? I know that many people do this, but in this particular case where you did not properly position the access device, maybe I would have used other stents, and they are also small size scaffolds, and in this case 2.5, the risk of a thrombosis is a concern in this particular setting.
The only reason to, let's say, the decision to use at the beginning of the procedure scaffold was because with the access I will cover the carina and the 2 access will go to the main side branch without touching the carina. After the complication, I mean after the incorrect releasing of the stent, I decided to continue with these 2 types of stents because I said, and I write in my conclusion, if this patient with his problems with restorative occlusion have some problem, I can, as we suppose that bifurcation by IVUS disappear, then there is a space for another treatment of this LAD on the diagonal branch. That was the decision.
Anybody else? Yes? One more comment.
The surgeon would have had the option to treat this patient because the lesion was very proximal. So I would have explained this if you had a very diffuse disease, but actually you implanted just 2 short scaffolds.
The stents are 25 millimeters long. The It was not short lesions, either on the LAD or the diagonal. It was a long lesion, controlled by the IVUS before the procedure, or 28 millimeters.
Yeah, apart from the cost and the scaffold, because I have some concern of, as I said, the cost, scaffolds that you use in this case. Cost using the IVUS pressure wire, same patient, and they actually did not rely on pressure wire assessment, and you went to put your strategy upon your IVUS morphological status. Why did pressure wire, since you will not rely on?
Very simple, because the steroids.
It was not significant.
The post-steroids were significant and geographically, and the decision to use FFR was because after the procedure, I decided, even with the IVUS, to use anyway in this patient FFR, because this patient had 4 times thrombosis instance, so I had want to be completely sure that everything is perfect. Unfortunately, not.
Okay. Thank you very much.
Thank you.